All right, so I just wanted to do a quick slideshow. Well, not quick, but a slideshow kind of just running down some of the stuff that you would see. Since you guys aren't going into clinicals, I just felt like it was important to point out some of the different stuff that you see in OB. So as I was making this, all I kept thinking of is Little Mermaid and her gadgets. So there you go. All right, so first and foremost, I want to make sure everyone understands the fundal height. So this is what we're measuring at every prenatal visit to make sure that baby's growth is correlating with how far along mom is. So I have some charts on here, also going over the prenatal visits once a month, and then it goes to once every 2 weeks, and then once a week. And that could be different depending on the provider. And then there's a nice little tool down here that kind of shows what happens at each appointment. Okay. And this shows the height there, and this is how we measure. So we're pushing to feel where the pubic bone is there, and then going to the top of the fundus there. All right, so the other thing was Dopplers. So this is how we listen to baby's heart rate in the prenatal appointments. It is just a handheld Doppler. You use the same exact Doppler when you're listening for pulses. Pedal pulses, I use this Doppler a lot. I remember when I was in nursing school doing my med-surg rotations, same Doppler. So the key is knowing where baby is. So how far along is mom? If she's not very far along, baby's going to be way down in there. So really low in the abdomen. So you kind of get to know where to look. And then as mom gets farther along, where baby lies. Sometimes mom knows better, like which side baby lies on. And then you just hold it on there. And you can see the numbers on the screen here. This would mean that the baby's heart rate is about 158. And it's going to fluctuate, which you guys would know going through the modules about fetal heart rate monitoring. It's going to fluctuate. But this is, you'd want to hold it on there and make sure that it's giving you a consistent rate. Okay, and then this just talks about when you can first hear the heartbeat. Remember, the heart is the very first thing that develops, so we can hear it very early on. And you can actually even rent these Dopplers, but I sort of suggest against it because it can cause a lot of unneeded anxiety if mom is unable to find the heartbeat. We had many, many moms come into triage and say, oh my gosh, I can't find a heartbeat. And it's there. They just, weren't sure where to look or what have you. So it's kind of hit or miss as far as if it's helpful or not. Some moms that have had recurring miscarriages, they feel better, getting up every morning listening to baby heartbeat. Okay, so here is just a picture of lightning. So this is when baby drops down into the pelvis, getting ready for delivery. However, it doesn't mean that mom's going to deliver the next day. Remember, everything is so unpredictable with labor, but this does mean baby's, engaging down, getting ready to deliver. So what can happen with mom is all of a sudden she can breathe better, right? Because you can see that baby was pushing up on the lungs here and the diaphragm, and now all of a sudden baby drops down and mom's like, oh my gosh, I can finally breathe. So remember the terms lightning and then what is quickening. Remember, that's baby movements. And then this is just a picture of a labor and delivery room. I did put in one of your modules like a tour of a labor and delivery room. I would definitely recommend doing that. If you've never been into a labor and delivery room, make sure you go through the virtual tours. Most hospitals have virtual tours now because of COVID. I used to do the birthing tours for Mercy Gilbert, and it was always so much fun because a lot of people have never been in these rooms. So it's always fun to explain to dad, this is where you get to sleep. See this nice and cozy couch right here? So this is mom's bed, and then we have the baby warmer here, and this is a labor room. So this is, every hospital is a little bit different, but this is usually where mom would deliver, and then she would get transferred to a postpartum room. Sometimes they stay in the same room the whole time. All right, this is a peanut ball. So if you do not know what a peanut ball is, you may not ever see one if you didn't do your OB rotations. So I wanted to make sure that everybody was familiar with the peanut ball. So It's actually very, very cool. Lots of studies have been done on this now. It is very helpful for moms. I mean, it can be helpful for anyone, but especially so for moms that have had an epidural, because moms that have had an epidural are not able to get up and move their pelvis around, and that is what we need. So this peanut ball opens up the pelvis. So you can see all these different positions that we move mom around in to just open up that pelvic area so baby can descend down, right? So lots and lots of research done on this that it can actually decrease cesarean rates because this can help progress labor. So you do have to do a lot of finagling with mom because usually she's not able to move her legs when she's had an epidural. So there's a lot of scooting, you know, laying her legs, getting her comfortable. And then of course you want to maneuver around so that she's in different positions. All right, so these are the TOCOs. These are the fetal monitors. So I just wanted to give you guys a really good visual of it. So down here, you'll see the TOCO transducer. This is actually the contraction monitor. I like this picture because it takes it apart. But on the inside, there's actually these coils. So what this is measuring, this is going to go at the top of the fundus, at the top of the uterus, so that we can actually tell when mom is having a contraction. Okay, that's the key. This is measuring if there is a contraction, not how strong it is. So don't forget that. With these external monitors, we cannot tell how strong the contraction is, no matter how many people try to tell you. I remember I was with my friend, my best friend, and she was having her baby, and her mom was in the room, and I was in the room. Her husband was deployed, and her mom kept looking at the monitor, and the numbers do go up on this. When you start having contraction, the numbers do climb because essentially it's kind of making a mountain, right? So the numbers start to go up, and her mom would be like, oh my gosh, this is a really big one. This is a really big one, and like freaking her out. And I was like, stop, please do not do that. So it does tell us if you're having a contraction, how long it's going for, and as it starts coming down, because the tightening of the uterus lets up. So that's what this one is measuring. The other one is the the blue one right here, these two blue ones. So this must be for twins because they have one contraction monitor and two of the Dopplers. So this is basically the same thing as the ultrasound Doppler handheld one, but this is just going up against the stomach. So you can see here, you would need to know where baby is laying so that you're going to put this where the heartbeat's going to be heard the best. And this is what can be tricky because mom's moving around, baby's moving around, so finding baby, I usually would ask mom, like, where do you usually feel baby kicking, and just try to get an idea. You can do those Leopold's maneuvers, to feel where baby's at. And that's where you're going to place this transducer. You do have to put some jelly on there, like lubricating jelly on these heart rate ones, because remember, it's acting like a Doppler. And then these are just the little straps that go around mom's belly. They're super thin and elasticy, but they can definitely be a pain. And then here's the machine. And these, plug in to the specific areas here. And then there's a printout here. And then you see the numbers also. But then you're watching the main monitor on the computer monitor. So this is just another visual for you so you can see how you would want this to be, where the baby's heartbeat is going to be heard the best. And then this is going to be the top of your transducer for your TOCO. So when baby is moving around, you're going to hear it. Okay, it's like, that's not very good. I don't do sounds very well, but you're going to hear baby moving around, baby kicking. Baby has the hiccups, you hear it because you're hearing like every time that they have the hiccups, right? Because it's, like I said, it's just that ultrasound Doppler. This is another picture here. That is one thing I think as an LPN that you probably can just like replace them on the monitors. It's going to be facility dependent, but that might be one thing that you would do. It's very important that if mom comes off the monitor at any time, it's documented. So fetal heart rate monitoring and documenting is so tedious, you guys, because you take mom off the monitor and something happens to baby, you better have a good reason why. or if the monitor goes haywire or something, you need to document every little thing and justify what is going on exactly. If mom's getting up to the restroom, you have to mark it. You know, every little thing that's going on has to be documented. You're adjusting the monitors, you need to mark it, right? Because adjusting the monitor is going to make the lines all over the place, right? So you need to document that, because what's going on? Is baby having some kind of a decel, or what's going on? You need to document what's going on. Some more pictures. This is exactly what it looked like last time I was at bedside. Mom's right here. You have your monitor, and then you'd have a computer monitor up here, and then the paper tracing just in case, or some hospitals still want to print out the paper tracing. This is just another picture here. And then this is actually a wireless monitor. I think it was called the Novi. And they started using these at Mercy Gilbert, but they were supposed to be for like obese women, but they just were not very, when I last was there, which was many years ago, but they weren't very successful with tracing. So I don't know how often they're using them now, or if they fine-tune them. But there's two different kinds of monitoring. Intermittent monitoring would be sometimes with the Doppler, but sometimes that means just hooking mom up for a certain amount of time, whatever the provider says, and then they can be disconnected, and then they can walk around and move around. And that would be, you know, maybe for a mom that is not having an epidural, everything's going well, they want to get up and get moving, right? Because labor doesn't happen just because, like, you have to move your pelvis around. So that oftentimes will be the case if there's no complications. And then the continuous monitoring would be mom is on the monitor unless she has to get up and go to the bathroom. There is also, you can get a wireless box that you disconnect these wires right here and then plug them into the box, and mom can carry the box around. But because it's wireless, I never really had that great of success with them. But they are there. And then your blood pressure cuff hooks up to here. Your pulse ox hooks up to here as well. So that's how we're monitoring mom. You can set your blood pressure to go off at, you know, at certain increments, and then you'll be seeing mom's heart rate and pulse ox as well on the monitor. So you always want to make sure and differentiate mom's heart rate from baby's, which should be definitely obvious. Okay, this is just a quick little slide. I know you have these presentations in the modules, but just a reminder how to time contractions. So how long is the contraction would be from the start of the contraction to the end of the contraction, but how often they're occurring, the frequency is from the start of one to the start of the next. And this is important when we educate, you know, patients and whoever their partner is when they're timing contractions when to come into the hospital. Here is just another picture. Here's the monitor here. You can see baby's heart rate is 144 there. And this is a good visual. I liked it because it's kind of showing you what is going on with baby's blood flow during contractions, which is why it's really important for us to know how the baby is responding to contractions, right? And then these are our different fetal heart rate patterns. So there's a really good website that I linked in the modules. I do not believe you will be asked that much about fetal monitoring because you are not responsible for it as an LPN. But you should kind of be familiar in general with the different terms and what's okay and what's not okay at all. And just remember the veal chop is very helpful. But definitely late decelerations are going to be what we worry about the most, okay? So that's when baby's heart rate is going down after the contraction. So you can see these dips right here after the contraction. That's what we really worry about, okay? So go through this, make sure that you reach out if you still need some clarification, but I'm not going to spend a whole lot of time on it just because it does get pretty tedious, but go through, make sure you understand veal chop and the reasons for the different decelerations, okay? It's very, very important to understand that. Okay, I like this picture a lot because this is what mom looks like. And do you think it's easy to get up and go to the bathroom? No. And how often do you think mom's got to go to the bathroom? A lot. So I just wanted to give you an idea of what it's like. So you got to unhook her from everything. She goes to the bathroom, then you got to rehook her up. So that's what a majority of your time is spent doing in the OB world. And then just a couple of terms that you may hear when someone is getting their membrane stripped. This is just a picture of it. So the provider is just kind of separating the wall of the uterus and the amniotic sac there. And then this is the amniotic hook. So when someone is getting an artificial rupture of membranes, they will use this hook, and you can see it's got this little sharp spot on it there, and they basically are just breaking the bag of waters. And that helps release hormones, it helps baby drop down, and it really kickstarts labor most of the time. But you want to be confident that that's going to happen as a provider, because otherwise you're going to have prolonged rupture of membranes, and we don't want that because of infection. All right. Other things, the fetal scalp electrode is right here. So this is like a really weird looking thing, okay? And this is what it looks like on the end. So if you ever remember, like when you were in grade school, you had like a safety pin and you poked it through your skin, like on your thumb at the very, just like top layer of your skin. That's basically what this does on the baby's head. This shows a little wound from the fetal scalp electrode that you could see. But basically it just twists up underneath that very top layer of skin. And this is how you get the baby's tracing if you're having a really hard time. A lot of times in obese moms that we just cannot get a accurate external tracing on the baby. This is what we will have to do. Baby moves around a lot, whatever the case may be. This would be the option if we really need to make sure that we're getting a good, accurate heart rate of baby. And then the IUPC, which is the intrauterine pressure catheter, this is the picture here. This actually can be used to monitor the actual strength of the contractions. So remember, the external monitors are only giving you an idea of when the contractions are happening and how long, but not how strong they are. This is actually giving you a measurement called the Montevideo units, and don't worry about calculating that, but it will actually give you the strength of the contraction. So this will be important when you're using, those induction or augmenting medications like Pitocin. Like, is it really helping? Are the contractions really stronger or not? And then this also can be used to do an amnio infusion, which could be used if they have low fluid levels, and sometimes we would use this if they have prolonged rupture of membranes, meconium stained amniotic fluid. There's several different reasons. The biggest reason that I have seen it used, I feel like, is probably low fluid levels. So just remember your terms. The oligohydramnios is going to be low fluid, and polyhydramnios is going to be excess fluid. Okay, and there are complications from both. So you should look those up and just kind of be familiar with what that could mean. This is an epidural. I just wanted to give you a visual because as the nurse, this is what you're doing. You're just kind of comforting mom. I think this might be a man getting an epidural. I can't really tell, but anyways, that's how you would be. This is in the OR, but this would be at the bedside in a labor room. So you're just kind of walking mom through it, telling her what's going on. Remember that she's usually having some pretty significant contractions during this process. So I can remember so many times anesthesia getting frustrated because mom starts moving, right? And they're trying to get the epidural in as if you can control her contractions. And then one time I had a patient that started, anesthesia was coming through the door, and mom lifts up one butt cheek and starts screaming, and usually that means there's a baby coming. And sure enough, baby starts coming out, and anesthesia literally just was at the doorway and goes, "Well, I guess you don't need me anymore," and turns right around and leaves. And I'm like, really? So, yeah, they pretty much come in, do their epidural thing, and they're out of here. So this is the epidural cart that's usually in the hallway. That's usually what we prep for them, pull it in there, get it all set up for them so that they are ready to just come in, do the epidural, and get out. So they're going to prep the back, and there's all their little tools there. Usually we explain to the patient that it feels like a bee sting because obviously they have to use the numbing injection, and then they feel pressure, and then they usually feel like a warmth down their legs. Very, very quick procedure usually. Sometimes not so much. Sometimes they might have a few tries, and that's always frustrating, but everybody's anatomy is so different. But one of the big things that you're responsible for is monitoring mom for hypotension. So it's very, very important that we're checking her blood pressure and making sure that she's not having a hypotensive episode, because what does that do to baby? And then here's a picture. We basically just, anesthesia will go ahead and prep this. And this is the epidural catheter right here. They just put this clear film on there and it goes up and then it hooks to the pump. So this is a picture of it. I don't have mine anymore. I used to have one just to show when I did childbirth classes because everybody is so shocked. They think it's like this needle right here, but this is just the needle that they put in to feed the catheter through. The catheter itself is so thin and flimsy and stretchy. It's really nothing. But to remove the epidural after mom delivers, and when this is getting removed, you do actually have to get checked off by the anesthesiologist. One of the biggest things that we have to document when we remove it is that it's intact. See this little black tip here? We document that that's there, so nothing was left in mom. And it really, you just have them bend over and you just pull it out. And I remember the first few times I did it, it was so scary because it sometimes gives you a little bit of resistance. If you have too much resistance, then you call anesthesia and they come and do it. But, it made me so nervous the first couple times I did it, I remember. And, it doesn't hurt them or anything. And then here is the labor bed. I just wanted you guys to get an idea. Again, I know you're not in clinicals, so I just wanted to show you what it looks like. I used to call it the transformer bed because it literally does all kinds of fun things. This is my favorite position right here. I believe we called it the throne position where they sit up. It can really help move baby down into the pelvis. And then we have the squat bar here for moms that obviously don't have an epidural and want to do the squatting. And then this right here comes off completely. Now the key is you do not want to take this off until your provider is there ready to deliver the baby. So that completely comes off. But again, we would not take that off until the provider was there, all gloved up, ready to be delivering. Because otherwise, you don't want a baby on the floor. And then you can see the stirrups here also that are really helpful. Okay, so another thing that I always like to point out is a stool. I remember when I first started in labor and delivery, I was like, why is there a stool in every room? Is there like a short nurse or something that has to have a stool, right? And then I remembered that we did talk about it in class, of course, but the first time that we actually had a shoulder dystocia and they're like, grab the stool. And the nurse kind of ran to under the bed and grabbed the stool from under the bed. I was like, oh yeah, that's right. That's what this is for. So after that, I was like so paranoid. Every time I would get a new room assigned, I was like, is the stool there? Is the stool there? And, I'm not short, but you need a stool usually when you're doing this McRoberts maneuver and suprapubic pressure pushing down. So usually you're going to pull the leg back, pushing down. And most of the time, the OB is going to tell you where to push. So it's a pretty stressful situation when there's a shoulder dystocia. And I think that's probably the time where I've seen the OBs really stressed. Like, when they're really stressed, something's not right. So it's pretty scary. And then we have two pictures here. This is a nuchal cord, and they have the cord wrapped around their neck. They can have, the cord wrapped around their neck, usually, I think the most I've seen it is a nuchal times 2, which means it's wrapped around there too. I'm sure it's more. When you Google it, there's pictures of more. And then this is the umbilical cord prolapse. So this is when baby's umbilical cord is coming out before baby's head. Okay. So those can definitely be complications for sure. So let's just talk really quickly about the umbilical cord. So remember that we have 2 umbilical arteries and 1 umbilical vein there, and then this other gooey stuff here is called Wharton's jelly. So when you're delivering or in a delivery room and you're the labor and delivery nurse or you're helping, whatever it may be, part of the delivery is collecting cord blood. So it's actually one of the coolest things, I think anyways. But if you can tell from this picture right here, I have seen several nurses stick themselves drawing cord blood. So it's something you definitely want to be very careful with, because if you stick yourself, it's the same as if you stuck yourself with any other dirty needle. I put some links on here. You can go through and research and watch the videos because they're actually pretty cool. But you're going to draw 1 syringe from the vein, which is this big chunky one, and 1 syringe from the artery there. And then I just put this picture in there to give you an idea of what's happening with the umbilical cord here, because we clamp on each side and it's cut in the middle. And I think I have a picture, yes. This is usually how the OB leaves it. So as the nurse, we have to trim it down to where the clamp is, because usually the baby is just like this left with the clamp on there. And I really like this picture here because this shows you what the umbilical cord can look like. They look different, all of them, but I love these little swirly ones. And then this is the umbilical clamp that it's clamped with. Again, this is clamped here, so we can trim it down all the way to the clamp there. And then just some pictures of the placenta. I know I put some of these in the module as well, but remember that the fetal side is like that shiny side, and then the maternal side is kind of the lobes and chunky spot there. And usually if mom has any fevers or concern with infection, we are going to get a culture. So we're going to swab each side, and you have to make sure that you label them correctly. And then this is just a picture of the placenta bucket. So it's going to go to pathology if there's any concerns as well, and it usually gets sent off in a white bucket like that. All right, so I think I'm going to stop there, and then I'll record the baby and postpartum. But again, this was just, I'm a really visual person. I just felt like, since you're not going to clinicals, I just wanted to give you a little visual of things that you would see on an OB unit. I'm sure there's things that I forgot, but it's just kind of a rundown of some different things. So I will record a baby one. Once baby is born, we'll go over those things. Thanks.